Hello, hello everyone. Am I audible? So today we'll be discussing with you all treatment planning. The treatment planning is nothing but the principle of orthodontic treatment planning in growing and non-growing patients. After complete orthodontic treatment is made, the next important step is treatment planning. The main objective of treatment planning is to design a strategy to correct the problems. Treatment planning is an outline of all measures that can be best instituted for a patient so as to she offer maximum and long-term benefits. Patient wants orthodontic treatment for a variety of reasons. The orthodontist should plan out a treatment modality based on thorough clinical examination and a proper diagnosis in a systematic fashion. So in this we are going to discuss all these subheadings. So what is after orthodontic diagnosis? First, to correct the pathologic problem, and second, to establish treatment goal, and third, treatment objectives. Next, we are going to assess the growth potential, assessment of etiologic factor, differentiate moderate to severe problems, analyze treatment possibility for different problems, treatment planning, space requirements, encourage planning, selection of appliance, planning retention, and re-evaluation. We'll discuss one by one. One is correction of pathologic problem. So before we are going to make any treatment plan, first we have to see whether any pathological conditions are existing in the patient or not. If any pathological conditions are there in the patient, we have to treat them first before starting orthodontic treatment. First would be periodontal therapy if any periodontal problems is there, or if patient is having any caries, then go for restoration. And patients sometimes may be having some medical problems that can be treated first. Then second will be treatment of patient with the proper goals. Goals means once when you get the treatment done, the following should be present in the patient mouth. The first important issue should be patient problems, and patient whenever we make a treatment plan, it should be the treatment plan should focus on the patient's main chief complaint. Then improving the facial appearance, reducing the overjet, corrections of crowding, establishing normal overbite, establishing functional occlusion, correction of molar relation, and maintaining stability of corrected malocclusion. Now objectives. The orthodontic should enlist the problems that have to be attended to in a decreasing order of priority. It means the treatment objective should be such a way that the, the the problems has to be written down in a priority basis. Patient chief complaint should be written in the first priority. Then other problems such as overjet, overbite, crowding that should be given second priority. Means whatever patient is having a more complaint, we have to treat the patient complaint first. Then we have to try to get a normal occlusion. During setting up the objectives, the patient's chief complaints and parental desires should be given adequate weightage. As I said, the weightage has to be given for the patient chief complaint and their parents' desires. Next will be the assessment of growth potential. Now we have to assess the patient growth, whether patient is growing or non-growing. If patient is growing, then how much growth is still remaining in the patient, that has to be assessed. If patient is growing, then growth modulation therapy can be given. If adult patient is there, then there will be limited treatment procedures there will be only tooth movement can be possible or surgical procedure can be possible. Next will be the assessment of etiologic factor. As I said, there are many etiologic factors that can cause a malocclusion. The etiologic factor has to be find out before starting or before making your treatment plan. Etiologic factors can be a thumb sucking, tongue thrusting, mouth breathing. These habits will lead to proclination of incisors or spacing between the teeth or mouth open bite. So you have to assess any etiologic factor. If they are present, then that has to be given weightage to treat first. Now, how to differentiate moderate to severe problems? A thorough database and complete problem list helps in differentiating into mild, moderate, or severe problems for proper treatment planning. Every patient has to be categorized into mild, moderate, and severe cases, depending upon the severity of the malocclusion. So, what is mild, moderate, and severe? We'll see what are the mild cases. Mild cases are where there is a proclination of incisor, retroclination of incisor, mild crowding, any rotations of the dentition. This comes under mild problems. The moderate problems are facial asymmetry, excess or deficiency of the maxilla or the mandibular bone. This comes under moderate case, whereas syndromic cases or developmental abnormality cases comes under severe problems. Next, the question arises: what is the timing of orthodontic treatment to start? It can be divided into three categories: early treatment, late treatment, and very late treatment. Early treatment, in that the primary dentition and early mixed dentition period. Late treatment, late mixed dentition or early permanent dentition period. Very late comes under adult stage. So, what is the advantage of treating patient which is early primary dentition or uh, early mixed dentition stage? The advantage will be there are many advantages such as we can change the skeletal and dental structures, and early treatment of harmful habits is easier, which means any etiologic factor can be treated easily, and significant correction of jaw problems can be achieved. Growth modification is possible if you are doing the early treatment. Then there it is psychological advantage to the patient. The main disadvantage would be continuous growth nullifies the effect of treatment, and child behavior management may be difficult. Usually requires second phase of treatment if you are doing early treatment. Next is mixed dentition stage. In the mixed dentition stage, the advantage will be the most patients are treated during early adolescence or early permanent dentition. Child cooperation will be good. Care of appliance also is better when compared to children in primary dentition. And here we'll have adequate growth remains so that growth modification is also possible. The entire permanent teeth problem can be controlled. Limited duration of time when compared to early treatment. The disadvantage of starting in the mixed dentition or early permanent stage will be delayed correction of protruding incisors can cause trauma to incisors. It means if you're doing a long-term treatment, then it may cause deleterious effect on the root apices. There will be root resorption, or sometimes patient may not continue his treatment because long-term treatment. Just how to analyze the possibility of different problems. As we have said, there are different problems in the dentition, but treatment plan should be based on the problem related. Say, for example, patient is having a deep bite. We have deep bite can be corrected by any of one options. Can be corrected by extrusion of the posterior teeth or intrusion of the anterior teeth. It has to be decided based on the clinical examination. And crowding can be corrected by expansion of the arch or by extraction of premolars or proximal stripping of interiors. So there are different options for single problem. It has to be decided based on the clinical examination and patient requirement and the severity of the malocclusion. In case of skeletal tendency, what can be done? Patient may be having excess mandible or deficient mandible or excess anterior placed maxilla or posterior placed maxilla. In that case, we can do growth modification, or sometimes if it is a mild case, then it can be done with camouflage treatment. If patient is adult, then we can go for surgery. So there are different treatment options for a different problems. Now treatment planning for primary dentition. So how you are going to plan your treatment in the primary dentition, especially alignment. If patient is having a spacing in the primary dentition, it is normal. Even in the deep bite also it is normal. Expansion of primary arches is done in case where future crowding is expected. If patient is having primary dentition, there is a crowding in the primary dentition, then we can go for expansion of the arches. In case of loss of primary teeth, if incisors are lost early, so it is usually it is not required. If posterior teeth are exfoliated early, then we can go for space maintenance. Incisor proclination or retroclination can be sometimes it is self-corrected, or it may be due to any habits. The habits uh, habit breaking appliances can be given to correct the procline incisors. If patient is having posterior crossbite, it can be due to thumb sucking habits. So thumb sucking habit appliances can be given to correct the constricted arch. Or sometimes expansion appliances can be given to correct the constricted arches. In the primary dentition, if there is a problem in anterior posterior discrepancy of the maxilla or the mandible, the growth modulation can be done. In the vertical problems such as deep bite, it is mostly a self-correcting. No need to give any treatment for the deep bite. And if patient is having an open bite, then it is due to sucking habits can be treated with habit breaking appliance. So these are the different problems, the different treatments, moderate problems and their treatment. If patient is having any mild or moderate problems can be treated with the orthodontic appliances and growth modulation. If patient is having the severe problems, which can be treated sometimes treated with the growth modification, or sometimes it can be done with the help of surgical procedures. In late mixed dentitions, mostly done with the extraction of teeth, growth modulation, and surgical procedures. In treatment planning in adults, the patient is having crowding, severe crowding, or missing tooth, crossbite, which can be done with the fixed appliances, sometimes removable appliances, and open bite and deep bite cases can be treated with the help of fixed appliances. So now, planning for space requirement. If patient is having severe crowding, then we may have to extract the premolars. Okay, sometimes all premolars, in some cases only upper premolars, depending upon the severity. If patient is having rotations, then we may have to do proximal stripping, or sometimes we may have to extract the tooth, leveling alignment, especially in the deep torosity. Then, then also we may have to do some extractions or expansion of the arches. Say sometimes molars is mesially migrated. In those cases also, We may have to do molar distalization, or in some cases space may be lost due to anchor loss. In that cases, we have to slice the molar to gain the anchor, to gain the space. There are different methods of gaining space: use of existing space, proximal stripping, expansion of the arches, extraction, molar distalization, uprighting of molars, derotation of posterity, and proclination of anterior. These are the different methods to gain the space. The patient may be having a crowding or a rotations in the anterior teeth, or there may be proclination. In those cases, we may need some space to align them. For that, these are the different methods to gain the space. As I have said, uh, the space gaining method can be decided based on the patient problems, based on the clinical examination. Next will be the encourage planning. So how you are going to plan your encourage? It is depending upon the number of tooth which is being moved. If the greater number of the tooth is being moved, the greater will be the demand on the encourage. The type of tooth movement also depending upon the type of tooth movement which are going to move. If there is single rooted tooth, requires less number of anchor. If multi-rooted tooth require more anchor unit. Duration of treatment. If the treatment duration will be the longer, then the anchorage teeth should be strong enough to hold it for the longer period of time. So greater will be the chances of the anchor loss. Next is the selection of appliances. So it depends upon number of factors. As I said, growth potential. If growth potential is there, then we can go for high functional appliances to correct the malocclusion. Depending on the type of the tooth, if you want a simple type of tooth movement such as tipping, rotations, this can be done with the help of removable appliances. In severe rotations, especially premolars and intrusion extrusion, these cases we need to go for fixed appliances, fixed mechanical, and also oral hygiene. If patient is having good oral hygiene, then it is an essential part of orthodontic. However, fixed appliances place an additional demand as they pose greater risk of caries, decalcification, and plaque. So, if patient is oral hygiene is not good, then we can go for removable appliances. Patient hygiene will be better. We can maintain patient if maintaining good oral hygiene, then we can go for fixed appliance. Next comes the cost. If patient is able can pay more for the appliances, then we can go for fixed appliances. If patient economic status is not good, then we can go for removable appliances. The next will be the planning retention. Once treatment plan is done, then we can plan for retention. After treatment, how we are going to retain the corrected malocclusion. In case of stress periodontal ligaments, we have to give for long-term retention. Usually, we give fixed retainers. In case of unstable occlusions, in that cases also we have to give long-term retention appliances, the removable appliances, and say for example in continuous growth pattern, if growth is still remaining, then also we have to give for myofunctional appliances or retention appliances which can be used till the growth completes. So these are the cases where we have to give retention for a long period of time, especially in the stretched periodontal ligaments, if growth is still remaining and in severe rotation cases. So to give long-term retention. After retention, we may have to call the patient for re-evaluation. Sometimes the treatment plan should be re-evaluated at the regular interval during the active phase of treatment so as to confirm whether the objective that were set up are being fulfilled. Changes might have to be made in the treatment plan if the desired changes are not taking place or if unforeseen problems are arising, which means after clinical examination, After the case discussion, we have to make the treatment plan list. After treatment plan, we have to make the aims and objectives of the treatment. Once the treatment is started, in between we may have to re-evaluate the case if it is not going well, or we may get some doubts in our treatment plan. Then re-evaluate by taking x-rays once again, taking impressions, do the dressing, all the dressings, all the process what we have done in the beginning. Then we have to do we have to see the corrections which are done till now. If it is going well, then we have to continue with the same treatment plan which is made in the beginning. If it is not going, if we're not getting a desired good moment, then we may have to change the treatment plan. This is called re-evaluation. It will be done in between the treatment. It can be done after 6 months or 8 months after starting the treatment. Thank you.